बिस्मिल्लाहिर्रहमानिर्रहीम। ये थोड़ी सी पुरानी तस्वीर है, ठीक है ना। सो इट्स इयर्स बैक। बिस्मिल्लाहिर्रहमानिर्रहीम। So, standing on the stage of a liver summit, I believe and I presume that most of you are endocrinologists. मेरे मुंह पे चढ़ गया है, तो that will maybe coming up. Most of you are hepatologists or gastroenterologists, and being an endocrinologist standing here says it all. When we started, endocrine was a small group, and then slowly and gradually the concept of metabolic health got extending. Sabse pehle we got hold on to the cardiovascular aspect of it, so we talked about the cardiometabolic health. Then we entered in the kidney as well, and then came the concept of cardiometabolic renal concept, CKM syndrome. And now with the change of these definitions, which we talk and see usually around, now here I pop up in the liver as well. The modern science have brought us together again. We were going in all different directions, and then it turned out to be that the actual core problem is the same, and you need to deal with the core problem. So knowing or presuming that you are gastroenterologist and hepatologist mostly, you must be aware of these new changes that happened few years back, and now we don't call these terms as non-alcoholic fatty liver disease or NASH, we call that MASLD and MASH. Well, the first speaker was expanding and talking about the fact that maybe liver is the central part, and everything initiates in the liver, and then it goes on around other organs. In metabolism, we believe the other way around, and maybe we both are right in our own sense, and maybe we both are wrong in some places. And here what we suggest that MASLD doesn't start in the liver, it starts in the adipose tissue, in the muscles, in the pancreas, and the liver pays the price as it goes on. I was contacted by the organizer of this session, and they asked me to convey these few messages, and this is how my present talk will be about. That I will talk about the metabolic origin. That is the important part, that I will try to explain to you that how everything starts in the periphery and in the liver, then it is the outcome of that. We will discuss a bit of epidemiology, what is the role of endocrinologist, and where we stand while we are talking about the MASLD. In the last presentation, you saw a pyramid where the cirrhosis was red on the top and the MASLD was green at the bottom of the pyramid. We stand at the bottom of the pyramid because we believe that if the metabolic health is improved in a good way, maybe we can prevent MASLD going on to the MASH and going into the fibrosis. You were listening to the first speaker, and he mentioned almost no drug of hepatology except resmeratrol, and he mentioned many drugs that basically initiated in the metabolic health and in diabetes. He talked about empagliflozin, he talked about semaglutide, he talked about tirzepatide. So all these drugs started for the glycemic control are now used even for the liver as well. We will be discussing the screening of MASLD as well as the prevention, and we'll discuss a few things about the pharmacotherapy as well. So this is how the definition stands, that the presence of hepatic steatosis in the adult in association with one of the metabolic risk factor after exclusion all the other causes of fat accumulation in the liver. And that's the criteria, that is ASLD criteria, which said that it should have all the three aspects covered before we label this patient is suffering from MASLD. The first one is hepatic steatosis, which is imaging on ultrasound. I guess you will know better this part from me because you deal with these things. So imaging with ultrasound and other modalities and the histology. Then comes the metabolic part. It can be type 2 diabetes. It can be overweight or obesity. It can be metabolic dyslipidemia, hypertension, and insulin resistance. And you have to exclude all the other significant causes of liver steatosis. When it progresses further, the hepatic steatosis plus liver inflammation plus hepatocellular injury plus minus fibrosis, that is MASH in the setting of metabolic dysfunction. This is not our domain because, as I said, that we stand at the bottom of the pyramid where we believe and we try not to let liver to lead to this extensive part. So what is my role? What is the role of endocrine MSLD? They is interlinked, and we consider that it is from the hormone to the hepatic fibrosis. The MSLD has a metabolic origin, and the most important thing that begins is insulin resistance. The previous speaker was referring to the same thing. Insulin resistance starts before obesity. Insulin resistance starts before type 2 diabetes. Insulin resistance begins before even pre-diabetes, before obesity. Everything comes after the insulin resistance. Most of us who are even thin, lean, non-diabetic, normal blood sugar level, non-obese, may still have insulin resistance, and that is the driving force for metabolic problems. And this is how it happens. What happens in the insulin resistance, then whenever there is insulin resistance, the job of insulin in a normal physiology is that it goes to the adipose tissue and it suppresses the hormone-sensitive lipase enzyme. As a result, the lipolysis is inhibited and the minimal free fatty acids are released from the adipose tissue that need to be carried to the liver. In insulin resistance, insulin cannot do this most important initial step. What happens when there is insulin resistance? The insulin fails to suppress your lipolysis. There are lots of free fatty acids generated in the adipose tissue, and these free fatty acids are taken to the liver where they are used for the synthesis of the fats in the liver. So the first concept of insulin resistance is that there is a chronic hepatic free fatty acid overload. What happens in the liver that it takes the free fatty acid, triglycerides accumulate in the hepatocytes, and then steatosis develop. 60 to 70% of the fat from the hepatic, from a patient with MSLD liver comes from the free fatty acid that has been generated from the adipose tissue. So that is the first source of the liver. And the other concept that is important in the insulin resistance, that we call it hepatic insulin resistance paradox. What is the role of insulin on the liver if we look at to the, this thing is not properly working. For this is for the carbohydrate metabolism, and that's for the fat metabolism. When insulin enters into the liver, it starts inhibiting gluconeogenesis. So no more glucose is created from the non-insulin substances in the liver. It suppresses glycogenolysis. जो glycogen store पड़ा हुआ है उसकी glycogen को storage को बंद कर देता है और glycogen synthesis को बढ़ा देता है. This is what insulin does in a normal patient. When there is insulin resistance and insulin cannot work properly on the liver, so these processes are stopped, or these processes are not working properly. So as a result, when there is failure of gluconeogenesis, there is suppression, so zyada gluconeogenesis hogi, zyada gluconeolysis hogi, and ultimately will lead to the hyperglycemia. The glucose will come from the insulin and it will go on into the periphery. So this is what happens in the insulin resistance in the liver on the carbohydrate metabolism. What happens in the fat metabolism, the job of the insulin in a normal situation is to stimulation of de novo lipogenesis. So that happens in the liver. लेकिन अगर liver में insulin resistance भी है, still it carries on. So this results in a phenomena which we call insulin resistance paradox, where the insulin resistance stage, there is increased release of glucose from the liver, as well as increased synthesis of the fat in the liver as well. So this leads to the concept that with this insulin resistance, the liver failed to suppress glucose production, but continue to synthesize fats, creating a paradox simultaneously causing hyperglycemia and steatosis. And these are the sources of the fat that is accumulated in the liver in MSLD. Almost 60 to 70% of this fat is coming from the free fatty acid from the periphery. 10 to 15% of the fat is absorbed from the intestine, and 25 to 30% of the fat of the fat is from de novo lipogenesis of the fat of the lipids in the liver. So this is what we call that insulin resistance is basically responsible for the accumulation of the fats in the liver. In addition to that, just not the free fatty acid flux is responsible, there is lipotoxicity in the MASLD as well. Not all look at the bottom line is that not all the liver fat is harmless. This lipotoxic intermediate that are produced in the liver because this high level of free fatty acid, it usually exceed the liver capacity to detoxify them, or beta oxidations के ज़रिए ये चीज़ें ठीक नहीं होती, and this result in a fact that there are lipotoxicity as well. So there is increased flux, free fatty acid flux to the liver, and there is lipotoxic variants, lipotoxic metabolites that actually ultimately leads to the, sorry, it's not going back. वापस नहीं जा रहा, back. If you can take it back, पीछे चले जाएं, और भी चले जाएं, एक और पीछे जाए, पीछे, हाँ, another one more, हाँ, बस आगे कर दे, good. So these harmful toxic metabolites ultimately leads the process of hypotoxicity, injury, and then inflammation, and later on the progression to the fibrosis. So a concept hormones का ये है कि there is insulin resistance, and this insulin resistance leads to a major part in the formation of free fatty acid. Then the other metabolic factor that plays a part is obesity, and there are a lot of hormones that comes from the adipose tissue. Adipose tissue is considered as an endocrine tissue, and these are hormones that are called adipokines. They are released from the adipose tissue, and they have their role in the metabolism and insulin sensitivity, and the most important them are our adiponectin and leptin. What does adiponectin do? Basically, it is a hormone that is secreted by the adipose tissue, and the job of this adiponectin is that it enhances hepatic and peripheral insulin sensitivity, increases the fatty acid oxidation, and decrease hepatic de novo lipogenesis, which we discussed in the previous concept, that there is increased de novo lipogenesis in the liver because of the insulin resistance. This hormone has antifibrotic activity, and what happens then obesity and type 2 diabetes, adiponectin is reduced, and because of the low level of adiponectin, there is decreased free fatty oxidation, increased de novo lipogenesis, and there is increase in the process of fibrotic changes in the liver. The other hormone that is important is leptin. Leptin is another hormone that is secreted by the visceral fats. And this hormone has the ability to suppress appetite via hypothalamic pathways. And in obesity, there is a leptin resistance. Leptin cannot pass the blood-brain barrier, and it cannot stop the hunger, and the person keep on eating, so it leads to further obesity. But what happens in the liver, that in the liver, this is a hormone that promotes collagen deposition and fibrosis and activation of the hepatic stellate cell. So brain mein to there is a problem through the blood-brain barrier, leptin resistance, it cannot cross and stop hunger, but in the liver, it still keeps on doing its normal physiological job, and it leads to the profibrotic hormone leading to the chronic liver problems, MASH and MASLD. Then it was discussed in the previous presentation as well that dyslipidemia has its own contribution, high triglyceride and very low density lipoprotein, increased hepatic delivery and storage system se zyada ho jate hain, they are then converted into toxic metabolites, free fatty acid increased ho jata hai, and there are atherogenic hyperlipidemias. So basically all these dyslipidemic problem, insulin resistance, ultimately lead to the MASLD, or ultimately lead to the fat deposition into the liver. Insulin resistance will increase de novo lipogenesis, increase influx to the liver, decrease free fatty oxidation, and ultimately lead to hepatic steatosis. Type 2 diabetes will accelerate steatosis, inflammation, and fibrosis, will increase the risk of progression. The obesity will increase free fatty acid. There will be lipotoxicity. There are different cytokines, adiponectin, leptins, and dyslipidemias as well. So we believe that this is all the metabolic problem that leads to ultimately to the MSLD and later on to the MASH. If you go through this statistic that globally the prevalence of MSLD is around in 30s everywhere across the world, almost with some reduction and increase. But if you look the prevalence of MSLD in patient with type 2 diabetes, it jumps up twice or 3 times to the normal patient, to the patient who don't have diabetes. So type 2 diabetes, MSLD prevalence is increased tremendously. Same happened with obesity. If you have a BMI of more than 30, it increased from 60 to 80%. In a morbid obesity, it increased from 80 to 90%. So we believe that MSLD is not a liver disease with a metabolic association. It is a metabolic disease with liver extension. Fine. So what is our role? Being an endocrinologist, where we stand. Now, if we believe and we have some idea that this is there's a disease that is a metabolic origin, and a metabolic physician can be of help to the hepatologist over here to reduce the burden from hepatologist. So we believe that progression, that is the most important problem. Many of us sitting here may live well with MSLD if they have a association, they know for sure that this will not progress to the fibrosis, and it will not become MASH, and it will not become liver cirrhosis. So the concept over here is from MSLD to MASH, from the metabolic dysfunction to the cirrhosis and fibrosis, we need to stop the progression, and there is a role of endocrinologist in the early part, and later on when it becomes MASH and fibrosis, then it is taken up by the hepatologist. We believe that 20 to 30% of the patient with MSLD progress to MASH over time, and the progression is usually from 5 to 10 years. But if you have these metabolic problems with it, like your patient is diabetic, obese, and have persistent insulin resistance, then this progression is faster, and it happens even at the lesser time duration, and the MASH may develop even from 3 to 5 years in patients who are at higher risk. So the concept over here is if we intervene early, there is a possibility that we may prevent or we may stop or slow down the progression of MSLD to MASH and later on to the stage 3 and 4 fibrosis and cirrhosis. As was mentioned previously as well, so what we can do at the metabolic aspect, that the weight loss, that is an important aspect of MSLD management, and believe that 10% of the weight loss have shown a very significant histological improvement. There is 67% NASH, which is now called MASH resolution, as compared to the 20% in the control, and the greater weight loss improve MASH-related outcomes as we go. So the systemic review and meta-analysis suggests that if a patient loses 1 kg of weight is associated with the reduction of 0.8 unit of reduction in the ALT, 0.8% point reduction in the liver cirrhosis, and the trend towards improved inflammation and MASH resolution. There's another data, which is a meta-analysis from 22 randomized control trial, showed that weight loss intervention reduced the liver enzymes, reduced radiological and histological statosis, and reduced the scoring and FLD scoring as well. So this is what the data suggests. 3 to 5% weight loss is associated with reduced steatosis. 5 to 7% of the weight loss reduced inflammation and ballooning. 7 to 10% of the weight loss, higher rate resolution of the MASH resolution and fibrosis improvement, and more than 10% of the body weight loss with a major reduction in steatosis. So weight loss is the first thing that, as a metabolic physician, that as a gastroenterologist or any other specialty you are working it, is something that can help your patient with MASH. The other thing that is important, a glycemic control in a diabetic patient. And the data suggests that if you control blood sugar level, the higher the HbA1c, the worse histological feature, and if you reduce your blood sugar level, so it will reduce the chances of MSLD and progression even after adjusting from BMI and lipids. So type 2 diabetes alone, if you are doing it without for obesity without for lipids, just control of HbA1c, and this is again independent of the weight change and the medication class. We will discuss this in a while. So A1c reduction in itself is going to reduce the progression of MASLD to MASH. That is irrespective of the patient is obese or not obese. This is irrespective of the patient is dyslipidemic or not dyslipidemic. Just HbA1c reduction with any drug, you will improve the risk of progression from MASLD to MASH. As we stand here right now, there is no drug license for MASLD in totality. We have drugs that has been licensed for the MASH, that is resveratrol and then semaglutide very recently, but we don't have any drug that has been approved for MASLD as a pharmacotherapy to reverse the MASH with fibrosis with metabolic control remains the cornerstone. But we have some data from some drugs which was mentioned in the previous slides as well. So if your patient has obesity, if your patient has type 2 diabetes, if your patient has metabolic dysfunction, rather than using any drug for this patient, we have some drugs which has data which will have impact on the liver as well. And the top of the list is semaglutide. Step 1 trial, those you are in endocrine, we all know that this was a drug trial that was done on semaglutide to look for weight reduction. But a subclass of this trial also had liver fat reduction was checked through this MRI proton density fat fraction, and it was, I am just explaining to you the cohort that was checked for this with this MRI as well. The trial was done for the weight reduction. So it showed that in the subgroup of 140 patients who underwent MRI, showed that this drug, semaglutide, showed 38% reduction in the liver fat, and patients with more than 30% liver fat reduction were 72% as compared to the 17% of the placebo. So the trial was basically done on this semaglutide, which was for the weight reduction, but this small portion of this patient underwent MRI as well, and which showed that there was 38% reduction in the liver fats. All the group in this patient, they have ALT was tested in all the cohort. The 149 patients, they had only MRI. With all the almost 2,000 patients, the ALT was the part of the normal protocol. So it showed that there was reduction of 13 units per liter ALT, and with the normalization of ALT was seen in few patients as well. So in this trial, which was step 1 trial, which was on the weight reduction for semaglutide, it showed that there was 38% reduction in this hepatic fat, as well as there were 13 units per liter reduction in the ALT in all patients. This then led on to phase 3 trial, which then was concluded, and now this drug has taken approval for the MASH, but it is not approved for the MASLD. So this is the data from the step 1 trial, which showed that with MRI, there was 38% reduction in the fats. There was 13 units per liter reduction in the ALT, which somehow translate into the hepatocellular injury. More than 30% reduction was seen in 72% of the patient, and there was no AST-ALT ratio rise, which showed that there was no progression of fibrosis in this group. Then there is another drug that is now the talk of the town. It is available in our part of the world as well, that is tirzepatide. Again, this is a SURPASS-3 trial, which was not done for the liver. It was a trial that was done for the comparison of tirzepatide versus another insulin, that is insulin degludec. But there was a small group which had an MRI subunit arm, which was to show the impact on the liver fat on this drug. And it showed that with this drug, there was reduction in the liver fat by almost, with the maximum dose, 48.9%, and the percentage of patients with more than 30% fat reduction were 82%, and the patient who achieved less than 5% of the fats, that is the normalization of the fatty MASLD, was 66%. All the doses were significantly important, but higher the dose, the better is the response. So again, this SURPASS-3 trial was not conducted for the liver outcomes, but one small group of the patients who were checked with an MRI, so they showed that this drug has a very great impact on the reduction of the fat. There is a phase 3 trial going on tirzepatide specifically for the biopsy approval, biopsy improvement in the MASH in the MASLD patient. So that will be maybe 2027. They are saying that they will release their data. So again, this is the effect. What happened, man? So it's the second drug, tirzepatide, which showed that this drug have a very massive effect on the hepatic fat reduction. Then the third class of the drug that has shown in the data that was discussed in the previous group as well, previous presentation was SGLT2 inhibitor empagliflozin. The empagliflozin have shown in the trial that this drug also have shown a bit reduction in the liver fat, which is not as convincing as was shown by semaglutide and tirzepatide, but it has shown that this has a reduction in the liver fat as well as there was a reduction in the. Okay, so that was the SURMOUNT trial, which was again done. So this was a summary. So, no, this के पीछे चले जाएं भाई, 2-3 slides पीछे चले जाएं. There are 2 slides on EMPA, पीछे चले जाएं और भी. यहाँ बस यहाँ पे रुक जाए, this is enough. So there's another drug called empagliflozin, which is SGLT2 inhibitor, and it has shown 13% relative reduction after 24 weeks of use, which is lesser than the one that was shown by the semaglutide and tirzepatide. The ALT was reduced, the AST was reduced, the FIP score was increased, and there was reduction in the triglyceride as well. The other member of this group is dapagliflozin, which again have shown that there is a reduction in the liver fat. There is an improvement on the imaging as well. There was a reduction in the ALT, and there was reduction in the AST, ALT, gamma GT ratio as well. So these are the group of drugs: semaglutide, which is a GLP-1 receptor agonist; tirzepatide, which is combined GLP-1 GIP receptor agonist; empagliflozin and dapagliflozin, they are SGLT2 inhibitors. These drugs have shown in their trial that they have a very positive outcome if given to the patient who has MASLD and not yet delivered MASH or fibrosis as well. So to summarize it for you, the take-home messages will be that we believe that MASLD is an hepatic manifestation of systemic metabolic dysfunction. Insulin resistance increase the free fatty acid flux and the hepatic de novo lipogenesis. Obesity and adipose dysfunction overload the liver with excessive fats. Type 2 diabetes accelerate the steatosis and disease progression. Dyslipidemia promote hepatic lipid retention and cardiovascular risk. And endocrinologists identify the MASLD as at the bottom of the pyramid in order to prevent the progression of MASLD into the MASH and later on fibrosis and cirrhosis. Weight loss, insulin resistance, dysglycemia, dyslipidemia, these are the common things that you need to consider. Weight loss is very important. Physical exertion is very important. Need to control the metabolic risk factor, diabetes, obesity, dyslipidemia, hypertension. I believe all of you will be doing that. And the last thing that we can consider, that if you are sitting in a liver clinic and you see a patient who has hepatic fatty MASLD and he is diabetic, you can review the medication what he is taking. If he is on metformin, DPP4 inhibitor, pioglitazones, sulfonylureas, the drugs that are not have any impact on the MASLD or liver steatosis, you can switch them yourself, or you can at least ask them that there are drugs that can reduce and help you in production in your real fat, and you need to go back to your physician. If you can do it yourself, that is very, very good. But if you can't, then it is better to switch these patients to the drugs. They have impact on the reduction of the liver fat, and these are GLP-1 receptor agonists. Semaglutide, used to be a very expensive drug still, but now we have the local manufactured semaglutide, which has reduced the cost of these drugs very much. We have tirzepatide available in Pakistan from the last 3-4 weeks, which is still expensive drug, but still it can be used. And empagliflozin and dapagliflozin are available, and they are comparatively very, very nominal and very cost effective as well. What we can do, the non-invasive force, that is not my job. If FEP score, maybe we can do, but the rest of the thing, liver enzyme, and we believe, and we all believe, that it is multidisciplinary care now, that we talk about cardio, metabolic, kidney, liver disease, rather than just a simple specialty where we are focusing on one thing. Thank you so much for your kind assistance.
Okay.